This lecture was prepared in collaboration with Dr. Anna Leftoff from the Radiology Department at the Hospital of the University of Pennsylvania, and many of our images are shared. We're going to talk about sonohysterography and go through some of the usual and unusual things that we see. Let's review the procedure. The way we do it is we start with a vaginal speculum examination. We find the uterine cervix, we cleanse it with betadine, and then we thread a little catheter into the uterus and blow up a little balloon. Not necessarily, we don't have to blow that up. Some people do it just with the straight little kind of catheter. We prefer to do it actually with the little balloon. I'll address that a little bit later why. Then we would take out the vaginal speculum and put in the ultrasound probe, and then instill slowly a little bit of sterile saline into the cavity, expand the cavity, and provide a nice contrast to see the endometrium. And we get such a picture. This is a beautiful delineation of a smooth, thin endometrium with absolutely no intracavitary masses. The indications for this procedure are to provide detailed, non-invasive evaluation of the endometrium. We do this in women who have abnormal uterine bleeding, whether they're pre- or postmenopausal. Even in women who have had a normal endometrium on transvaginal sonography, sonohysterography can find some abnormality in about 14% of cases. This was written up in AJR in 2002, where women had symptoms. Transvaginal sonography showed a normal endometrial thickness, but the sonohysterogram did actually contribute to a diagnosis in 14% of cases. We do it in patients who have endometrial thickening that's unexplained or needs further evaluation. It can be done in women with infertility and recurrent abortions to see the internal structure of the uterine cavity. In uterine disorders, congenital disorders or acquired, when the endometrium is not visualized on transvaginal sonography, somebody has to be able to evaluate it, and this is a good non-invasive way, or to further evaluate a finding on transvaginal sonography. The contraindications are, of course, pregnancy. We would not want to disturb a pregnancy, and active pelvic infection. We wouldn't want to spread the infection by flushing it backwards through the tubes. So if the patient is in an active state, she should be treated with antibiotics prior to this procedure. A lot of the women are perimenopausal, postmenopausal, so pregnancy is not an issue. There are relative contraindications, such as presence of an intrauterine device, which nowadays it is possible to do this, although 3D sonography is now a very good way to look at these IUDs, so it's really not necessary to introduce saline into the cavity. When there are bilateral tubal occlusions, the fluid usually freely floats into the cul-de-sac, so if the tubes are obstructed, we could introduce more infection that way. Or if you actually seriously think a patient has endometrial carcinoma, then that's not a good idea to introduce fluid because we're afraid of transtubal peritoneal dissemination of these cancer cells. That's a theoretical risk, and sometimes we do end up finding endometrial cancers on by this technique, but if you actually see a large mass and really think it is, we should not be doing this. So the usual finding is a thickened endometrium, which has to be explained further. There are a few little cystic areas here. The differential diagnosis here is thickening. Is it polyp? Is it hyperplasia? Or possibly carcinoma? Much less, it's not suspicious here at all. That's why we do our sonohysterogram, and we delineate a solitary large fibroid. We can describe how broad-based connection it is to the endometrium, and look for additional polyps. Another patient, postmenopausal with bleeding, endometrium is too thick, thicker than 5 millimeters, and we're looking to see, is there a polyp in there, hyperplasia possibly, carcinoma. And the sonohysterogram delineates an irregularly thickened endometrium, no polyps, so this most likely hyperplasia. Another mass that's in the differential is the submucous myoma, which is not always clear how much of it is within the, or how large the submucosal component is. So the sonohysterogram delineates that very nicely for us. Now, myomas tend to shadow. They tend to have some areas of shadowing, whereas the polyps tend to be homogeneous and hyperechoic and do not shadow. So here the sonohysterogram delineates there's only one. It shows us the connection, which wall, helps the gynecologist plan their surgical removal. Here's another patient, postmenopausal lady, has some bleeding, and we see a myoma, and we're not sure how much of it is submucosal, how much is intramural. So we introduce a little bit of saline, and we see that the endometrial cavity is clean. There's no areas of thickening, no polyps, and this is a transmural myoma that does not really protrude into the cavity, so there's no endometrial pathology. Another patient with abnormal uterine bleeding, and sonographically we're not even sure where the endometrium ends. Is all of this a thickened endometrium when we measure it? Is this adenomyosis? So what's going on? Sonohysterography beautifully shows us that the endometrial cavity is here. All of this is adenomyosis involvement of this posterior wall. So why would we do sonohysterography and not just go to biopsy? Well, this does not replace the need for tissue sampling. So this by no means replaces histologic evaluation. So histology is what makes the definitive diagnosis, but this is not replacing that. What we're doing is we're providing a roadmap for the surgeon. We're guiding them where to go for focal resection in the hopes of decreasing the false negative rate of hysteroscopy, which does exist. And we're picking up other findings. There could be multiple polyps. What about the patient who has a polyp removed hysteroscopically but continues to bleed and eventually is found to have additional polyps in the cavity? And sometimes there are mixed pathologies, but not just a polyp with submucosal myoma, polyp with some type of hyperplasia that's more serious. So information is always helpful for the managing physician. Here's an example of what I mean by hysteroscopic false negative. This lady had an office hysteroscopy, but continued to bleed. The hysteroscopy was negative. Subsequently, a sonohysterogram was done, and this showed that there was a myoma in here. There probably was some difficulty. This uterus is kind of retroflexed, difficulty getting to see the entire fundus, and in here was a polyp. So we can find multiple abnormalities. This patient had an obvious polyp, but there was a little one off on the side. So now the doctor knows, the gynecologist knows that there has to get 2 polyps out. Here's a patient with a dominant polyp and then a little adjacent one. Here's one with 3. A patient with multiple findings. This patient had a diagnosis of complex hyperplasia with atypia and an endometrial polyp. This patient had complex hyperplasia with atypia and associated polyps. All of that has to be, a thorough tissue sampling has to be performed when we see something complicated, complex manifestation like this. This patient had a polyp and a submucous myoma. There's a shadowing from this myoma, and off to the side was a polyp. And here's her cavity further away, actually multiple polyps.